Next we have Dr. Jodh Mehta from Singapore talking to us about reducing dysphotopsia, another frequent visitor to Indian meetings.
Thank you. Great. So thank you for the invitation to talk in this session. So I'm going to be talking about reducing dysphotopsias. These are my disclosures, really paint Telion at the top right over there. So as you've heard from the previous speakers, the evolution of cataract surgery has led us to a situation really where cataract surgery now is really a refractive procedure as a purely therapeutic procedure itself. And really, dysphotopsias are the most common cause of basically complications following routine cataract surgery. And this can occur with any of the conventional posterior chamber IOLs that we currently use in the market. You can classify them as positive and negative, and you can see from the pictures above on basically how these will occur to basically the patients as well. And it's important to really get a good history from the patients on the details of the surgery if you can, if you did the surgery yourself, or if they've had it done elsewhere, the patient's symptoms, the focus on the onset, the location in the visual fields, and some of the alleviating factors and how it's affecting their quality of vision when you're basically seeing the patients as well. Reassurance and validation is important, especially for negative dysphotopsia, because often this is excluded by many surgeons and dismissed with respect to causing any visual problems because their central vision is quite good. And of course, if you can look for obvious pseudofocal adhesions by looking at the fourth Purkinje image, this will give you some idea of the lens. So if we look at these individually, positive dysphotopsia, most of you will be more aware of course, you get this from a lot of the diffractive multifocal lenses, this unwanted lighting or flickering of the lens itself, and it of course comes from the obliquely rays coming across the edge of the lens itself. And this has been reduced by some of the technologies with respect to the edge profiles of some of the lens as well. It's important to basically treat any of the ocular surfaces if it's associated. This can significantly improve the symptoms of the patients. So I'll just show you an example of a patient that sent to me, an 68-year-old lady, Chinese lady, bilateral cataracts, normal fundal examination, had routine cataract surgery with a pretty good visual acuity outcome. At 1 month post-op, she noticed a streak of light around the individual light zone. And you can see unaided vision, not too bad, best corrected vision, very good. The streak was still presented with basically full correction and no difference with scotopic or mesopic condition, and she was told to basically wait. 3 months later, she came back to the same doctor, same issues as basically complained beforehand. This is what the eye basically looked like. And they were sent to me because they thought that she had some induced aberrations on the cornea and thought this may be causing the problem. So they thought that we could sort out this by doing some laser treatment. So at 4 months post-op, when I saw her in clinic, in fact, this is basically what she looked like. So the aberrations actually were completely fine, basically in both eyes, both on a tomography and also with respect to a spherical aberration itself. So clearly she's getting basically a streak light phenomenon from that basically lens itself. So the options were either to do basically a lens exchange or basically just do a YAG. So I thought, okay, well, you know, obviously if you do a YAG first, and then obviously the fold is on there's a mark on the lens, it's going to make your lens exchange slightly more difficult. So I thought, let's have a look at basically the capsule in a little bit more detail. And when I took it to OT, actually it was quite simple to basically see what was going on here, because basically once I started to shift the lens across from side to side, you'll see actually the crease itself basically just starts to disappear. So I started to lift the lens up, and then when I moved it a little bit, you see the crease basically just goes anyway. So this is basically a fold in the capsule, which I couldn't actually see on the OCT basically pre-operatively. So when I shifted the lens around, I was able to shift the flow out to basically one side, and I thought, okay, this will probably help alleviate her basically central symptoms. And of course, the reason why this happens is because very few of us actually even measure the capsular bag when we're doing our cataract surgery. And if you put the lens inside the bag itself, of course, larger bags, the smaller bags, it's going to have an effect on basically how you can basically get these creases. So, of course, the crease basically had moved to basically one side. She had better repositioning of her symptoms. And now, basically, she told me she only gets this at nighttime, and she was happier, basically, with her visual acuity result. And, of course, now she was keen for cataract surgery on the other side. So what are we going to do in that side? So I decided to choose a lens where I could basically exclude the whole issue of the bag size. And, of course, we YAG basically the left eye. So the lens I basically use is the Femtis lens. And the Femtis is a lens that basically clips to the anterior capsule of the eye itself. So normally the cataract surgery has to be done by flax in the situation. So normally the Z8 is basically programmed to have 2 extra ports on either side to allow me to do the manipulation after I basically do the surgery. The rhexis with the lens is about a 5mm rhexis. Then following the cataract extraction, you basically will see the lens will basically inject it inside the bag. It comes in the injector. The Telion injector is slightly different. Normally you have to check the lens to see the anterior flanges are basically correct. On the anterior surfaces, of course, this is going to clip to the anterior capsule, so it's worthwhile checking before you input the eye. There's different platforms available. This comes on a monofocal and also an EDOF platform and also a refractive trifocal platform as well. So once the lens is basically injected inside the anterior capsule, you remove all the viscoelastic basically from behind the lens itself. And then what I do is I inject a little bit of viscoelastic basically onto the surface, and then using the extra ports basically on the side that you've created with the femtosecond laser, you can basically then anterior enclave those little haptics basically onto the surface. There are 4 haptics, 2 large ones, basically 2 small ones. The viscoelastic is now going in on surface, and then I just go in with a Sinskey hook and just gently manipulate those anterior those flanges onto the capsule. The other advantage is, of course, if you're putting a toric lens in this situation, when you actually fixate it into position, it will be absolutely stayed in position itself because it will remain in the actual position on the surface as well. So you just put the 2 ones on the side. Okay, so this is basically how she ended up on the right eye, day 1, yagged on the left eye itself, and you'll see on the UBM basically how she's positioning of a lens on the anterior capsule basically on the UBM eye, and basically the ones in the back basically in the other eye, and of course the other advantage, you can reduce the astigmatism with this lens. So let's see the opposite case, a negative dysphotopsia. This is a Singapore Airlines pilot who had cataract surgery done by a colleague of mine, routine surgery, good visual acuity outcome, but was complaining of basically a shadowing basically on the left side of his vision. So she yagged him because she thought it may actually get better, and then after a year she sent him to see me to basically have a look. So this is negative dysphotopsia, and of course this occurs basically relating to this blank in the gap in the field of vision, and often you see this with the kind of edge effect of basically the lens itself, but it does improve to time, between 15 to 3% over basically 1 year. So again, he underwent, on this side, what I did was I did a reverse basically optic capture for him, because when we did a UBM, I could see there was a partial shift in the lens, and this is quite well treated if you can with a plate, with these haptics, with a reverse optic capture. You can rotate the lens, so it's in a 3 and 9 o'clock position to reduce the symptoms of this as well. And of course, if that doesn't work, you can always basically do an IOL exchange and a piggyback. So following his reverse optic capture, he was happy with the visual acuity result. He said the symptoms are only basically on his extreme side. And for the other eye, obviously we had a choice of either doing basically a femtis or putting a reverse optic capture to a primary procedure. So again, the surgery is the same as I've basically shown you previously. So the lens will go basically inside. So after basically clipping, I'll skip the video, which is in the interest of time, just to show you the clipping itself. So once the lens is in the bag, you can just basically adjust the haptics so they basically clip into position, and normally I give some Myocol to bring basically the pupil down at the end of surgery to just make sure the lens position and the flanges are nicely lying basically on top of the capsule as well. So, you know, he told me the surgery in this eye was basically completely different to what he basically experienced on the other eye. So with this lens basically comes in different formats. So this is the one that I basically use. I use the Femtis Comfort, so it's a refractive lens itself, so they will get distance and intermediate in there, and I often do a mismatch between the 2 lenses that will give them distance and intermediate and also basically in their mission, but it's affecting the ELP position of the lens that will allow you to get very accurate basically outcomes. This is a very nice little algorithm that was basically published, I think, at the end of last year, which shows you how to manage these patients with negative and positive dysphotopsia as well, and it gives you an idea to basically look at the timeline for basically these patients as well. And we don't see many of these cases, luckily, but I think it's worthwhile acknowledging them when you basically see them. So in summary, dysphotopsia is the most common complication after routine cataract surgery, and it can occur with basically any current posterior chamber intraocular lens technology. Clipping of the lens to the anterior capsule can avoid this problem with respect to negative dysphotopsia, and enhanced refractive optics of this lens basically will reduce the symptoms of positive dysphotopsia itself, independent of any capsulotomy variation, which is improved because you get accurate, effective lens position. Thank you for your attention.
Thank you, Dr. Jyot. We also have something called the negative dysphotopsia ring available to us.
That's right. Yeah, I saw. Yeah.
Yeah,
I haven't used. I mean, that's a piggyback, right? You're putting it on top
right.
of the lens as well. And I saw some trials. I think it comes from
the care
not Sam Mascot. It works with Nicole Fram, and it basically goes on crop on the surface itself
and covers the optic.
I think that's very useful if the lens. So if you have a plate haptic lens inside the bag, then I think that's a great option, right? But I think that, you know, you can, the ones I've done basically, and doing the retro reverse optic capture actually works pretty well. People have been quite happy with that. And I've been doing that as well.
And if the margin is visible, doing the YAG is the simplest option, I think.
For the,
if the rexus overlap on the nasal side is visible.
If you can see it, if you can see it.